Welcome, everyone. I'm Dr. Jody Jacobson Fry. I'm the co-chair of the Workplace Suicide Prevention and Postvention Committee, along with Dr. Sally Spencer Thomas. Thank you for joining us today as we have a webinar on reverse psychology, mental health concerns among mental health professionals, with two speakers today, Mark Defee and Sarah Gare. To tell you a little bit about our speakers, Mark is a licensed professional counselor and a board certified coach. He spent 2 decades in the employee assistance or EAP field, providing over 5 years of telephonic crisis intervention and stabilization services. Also, I'd like to spend a moment to tell you a little bit about Sarah Gare. She's a master's level clinician with 24 years of experience, has worked focusing as a suicide prevention specialist with law enforcement, and is also a master trainer for the Question, Persuade, and Refer, or QPR Institute. She's provided consulting services and trauma recovery for healthcare and is the co-chair of the Pioneer Valley Suicide Prevention Coalition and executive committee member for the Massachusetts Coalition. Recently, she's the recipient of the Massachusetts Coalition for Suicide Prevention Leadership Award in 2022, and she's also a 2-time author. So this webinar today is part of our National Guidelines for Workplace Suicide Prevention. The guidelines are supported through a collaboration with the American Foundation for Suicide Prevention and the United Survivors of Suicide International. Our guidelines are framed on 8 guiding principles. Today's presentation is actually going to include aspects of all of our guiding principles. In addition to our principles, we use 9 practices that go from upstream to midstream to downstream approaches to try to put the guidelines into action. Today's webinar will touch on all of the different practice areas, but we'll primarily focus on midstream and upstream approaches with peer support. So I'm going to turn it over to Mark to get us started.
Today we're going to run through 3 goals quickly. We wanted to start with discussing really the lack of data when it comes to mental health conditions and suicide risk within the mental health profession or counseling profession. From there, spend some time talking about some unique mental health risks for counselors, and then wrap up looking at some opportunities within the counseling profession to implement the national guidelines. The biggest problem when we look at the mental health profession is just collecting the data and encouraging people to report accurately, because it is something that has surprised me when I was preparing for this, that not only has data not been collected, it has been discouraged to report. It's interesting because within the medical profession, there is a lot of research, there's a lot of data collected. However, there really is a scarcity of literature related to the same concerns within mental health professionals. And in fact, in more than one place, I read that applying to graduate school programs, people are actively encouraged to suppress their background. Do not talk about it, because the admissions people might think that your mental health illness or conditions in the past could impact the way that you counsel people in the future. And so they said, tell enough to become empathetic. So the admissions people say, oh, they can connect with clients, but not so much that they have any concerns about you being able to do the work. And so people, before they even enter the profession, are being told, don't talk about it. And they're subtly getting this message that people really can't move beyond mental illness, because if it's in your past, then clearly you're not going to be able to do well in your future endeavors in this career. When we talk about some of these specific stressors or concerns, risks among the mental health professionals, you can see a long list of here in terms of professional burnout, apathy, easy access to psychotropics. But I wanted to focus on self-stigma. There is, again, this perpetual pattern of, I can't talk to anybody about what's going on, or I risk no more advancement within the field, and maybe even someone saying, I don't think you're qualified to be doing what you're doing. And so we keep it in. We decide that we care about our clients, and we are going to use our background, because I think all clinicians bring part of their background into session with them, but we don't talk about it outside of that, or even verbalize it, because of these concerns. And that's something, I mean, that's really the first thing that needs to change. And it is. There was a recent study published in the Perspectives on Psychological Sciences. It was roughly 1,700 people that filled out an online survey. It was actually conducted by an assistant professor of clinical psychology at my alma mater, Texas Tech. Go Red Raiders. And you can see that 80% of respondents reported lifetime mental health difficulties. And they wanted to separate out these two in case people wanted to report difficulties that might not fall within a specific mental health disorder. So 80% reported difficulties, nearly half reported a diagnosed mental health disorder. Yet no one is talking about it. Think about that. It's not like this is new. They've been going on for years, but we're just now getting data to look at it. And you can see at this bottom piece here, it is depression, generalized anxiety disorder, and suicidal thoughts or behaviors. Now, one caveat is that there has been data collected over the years regarding psychiatrists because they are more connected to the medical profession. And it does show that psychiatrists have a higher level of risk or suicide rates compared to the general public. But it needs to expand beyond that. We need to be able to look at psychologists and master's level clinicians and people in graduate programs right now and faculty. If we aren't able to collect that data, we're not exactly sure how to help people. However, over the last 2+ years, we've seen how impactful it can be. I worked for two large insurance companies, payers, Aetna and Anthem, in a telephonic crisis clinician role. It's a call center type atmosphere before the pandemic. So I could stand up and I could go talk to someone in the cubicle next to me, another clinician, and debrief on what that call was like when someone was in a high acuity state, in a crisis, and we were assessing and referring them and getting them to that next spot. When the pandemic hit, all these individuals went home. And so they lost that chance to debrief with people. They were turning around and they were seeing their families and their pets. And there was this inability to separate the two. And Anthem, specifically in the spring of 2021, saw this skyrocketing of short-term disability within their clinicians. And what the conclusion was is that these clinicians held on for about a year because they're dedicated to their work and they knew people needed them. But then they couldn't take it anymore. And Anthem in particular had to scramble. They had to not only begin hiring and training people, they had to make sure that these people out on short-term disability wanted to come back to Anthem. And then they also needed to make sure that the clinicians who were still on the phones and supporting members, they were supported, so they didn't need to take short-term disability. So they did start looking at things like peer support groups and spending more time in meetings processing it, which meant they need to train leaders on how to talk about these topics because not all leaders were clinicians that oversaw a clinical team. So there's a lot going on that needs to happen, not only during the pandemic and everything changing, but this has been a systemic problem for years and years. Now I'm going to hand it over to Sarah, who can tell us a little bit more about what has happened during COVID-19.
Thanks so much, Mark. It's so refreshing to have somebody saying these things out loud. I think the other thing that we don't talk very much about in this work is the exposure to trauma that so many of us are going to have during our careers. One of the moments that really changed me in this work was several years ago now, losing a beloved client to a heroin overdose. I knew, of course, working in substance use treatment, that was going to happen at some point in my career. At least the odds were likely that it would. But the shattered assumption for me was really in the lack of response from my colleagues and my supervisors. I had reached out to people, I had expressed concern, but of course I was afraid to show too much concern because that's the narrative of maybe you shouldn't be in this work, or maybe your boundaries aren't good enough and you've gotten too close. Which of course just leads me to the question, have we lost our humanity? To me, it seems that we should be heartbroken whenever somebody that we're working with dies long before their time. And so when I became the senior team leader for the FEMA-funded crisis counseling program in Massachusetts, it felt really important to me to be part of doing better than had been done for myself. And we had some early concerns. We were receiving calls from the community with people in really high distress. Unfortunately, because of our work with school personnel at the beginning of the pandemic, we were hearing about a lot of cases of potential child abuse, sexual abuse, and neglect. We were certainly having several days where there was overwhelming demands for support, and our staff were trying to support themselves and their families during a global pandemic, which none of us had lived through before. Not to mention, just to complicate things more for us, we were only working virtual, as was most of the world, but it really took away a lot of our normal, habitual ways that you would bond with people at work. This team was brand new to us, so we really wanted to make sure that we did something to help provide support to our team. So what we came up with was the need to have a peer support program. And it was actually a really unique process because we were able to engage our staff. We had many incredibly talented and smart people on our teams, and we were able to engage them in building this. So this isn't something that we sort of created ourselves and then put on them. We actually really created this with them. We were able to get 2 members from each of our teams who were nominated. We had regional teams. These folks who had been nominated to be on the peer support team actually performed the needs and strengths assessment. As part of that assessment, they interviewed experts, and the team designed all aspects of the peer support, including how staff would connect, whether it was by phone, by email. They created all different types of outreach and communication plans. And then, of course, we did have some formal training. Our staff were all already trained in psychological first aid, which is a pretty decent foundation, but we knew that asking them to do peer support was going to be a shift from their interactions in the community. So we also brought in Eduardo Vega to provide training specifically around being a peer supporter. And the team met weekly and created program policies and procedures. So how did we find our program got utilized? The most common referrals that we had actually came from supervisors. When staff people would be expressing discouragement or frustration, supervisors would just remind them that that resource was available, including in multiple occasions, we had staff who had contracted COVID-19 themselves, and they would share that information with their supervisor, who would then suggest that they could lean on the peer support. All of the feedback that we received about our program was very positive. One of the initiatives I think that was probably the favorite was our team sent out caring cards to the entire team to their homes, and people really, really expressed that that was meaningful to them. Our peer supporters also held coffee hours for both shifts. I believe it was monthly. Some months better attended than others. As you know, many of us ended up getting some screen fatigue, and certainly they did. And we did have an incident where we lost a very beloved counselor unexpectedly. And so the team was activated in a response sort of way, which of course brought up some new challenges for us because they were also impacted parties. So what are some action steps and resources? And I'm going to hit you with my call to action first. I truly, truly believe that we have a responsibility to role model what we're preaching out in our communities. I've been working with law enforcement for about 9 years, and they are doing peer support in large part because we've been recommending it to them. And yet we're not doing it widely within our field. I truly believe that peer support should be part of the fabric of the mental health field, suicide prevention. Also, the number one barrier you're going to face is around human resources concerns. And the wonderful news is that we have the Workplace Suicide Prevention Human Resources and Employment Law white paper that's coming out that should hopefully put a lot of those concerns to rest. And for the resources, we just want to back up. The first 2 bullet points there are the references for Mark's presentation. The third bullet point is the link to the peer support manual that we created with Sally Spencer Thomas and Eduardo Vega and Dr. Robert Macy, which really does help to make the argument about why peer support is so important, and then goes into the experiences at Mass Support Network and all that we learned in that process. And again, last but not least, I can't stress enough how excited I am because this definitely was one of our biggest hurdles. And that's the white paper about HR and employment law.
Thank you so much, Sarah and Mark. And I hope that many of you listening today will be able to take some of this and start thinking about how you can implement it in your own workplace. We here at the committee also want to call you to action and ask you to go to workplacesuicideprevention.com, where you can sign up to take the pledge to make suicide prevention a priority in your health and safety aspects of your workplace or your professional organization.